Okay, so this is the things. Next you can see here CT scan. CT scan is the gold standard for small bowel obstruction. It confirms obstruction and identifies transition point and detects causes and detects ischemia and detects perforation. Okay, in CT findings you can see dilated proximal bowel and collapsed distant bowel and transition point, closed loop obstruction, mesenteric edema and pneumatosis intestinalis and free air if perforation. Okay, so this you can see here, this is the normal obstruction you can see. Okay, so the fluid and gas accumulated. So non-linear boundaries indicates a small bowel obstruction. Okay, so contrast enhanced CT is the investigation of choice for suspected small bowel obstruction. So next we can go with ultrasound. So this ultrasound is main useful for children and pregnant women and bedside assessment. So what we are going to see in ultrasound, dilated bowel loops and increased peristalsis in early cases, free fluid and thick bowel wall. So the gas fluid bowel reduces image quality. So this is a thing. Now severity assessment of small bowel obstruction. We can divide into three different classes. One is mild, moderate and severe. In mild small bowel obstruction we can see stable vitals, partial obstruction and no peritonitis. Next we can see moderate small bowel obstruction like persistent vomiting, significant dehydration and electrolyte imbalance. Next we can see that is severe small bowel obstruction like shock, peritonitis, ischemia, perforation and sepsis. Okay, so if in differential diagnosis we saw some paralytic ileus. In paralytic ileus, how to differentiate means the patient we can see absent bowel sounds and diffused bowel dilation. In large bowel obstruction we can see marked abdominal distension and late vomiting. And acute pancreatitis means the raised serum, the increased serum lipase and epigastric pain. And gastroenteritis means mostly we can see diarrhea and diffused cramps. And we can see like mesenteric ischemia will be like severe pain out of proportion to examination, and perforated peptic ulcer, the free air under diaphragm. Okay, so these are the things. Next we can see here the diagnostic next you can see here that is management of small bowel obstruction. The main important thing, the management, what we are going to do, what is the main goals we have to treat the small bowel obstruction: to save the patient's life, to correct dehydration, to relieve bowel obstruction, to prevent bowel ischemia, to treat the underlying cause and to prevent recurrence. So resuscitation before operation is the cornerstone of successful small bowel obstruction management. In management you can see here, first we have, whenever you are suspecting the patient with suspected small bowel obstruction, we have to do primary survey, that is ABC assessment, airway breathing, airway, the always we have to ensure the airway is patent or not, and we have to go with breathing, oxygen, if saturation is less than 94%, we have to give oxygen supplementation. Next we have to go with circulation, like 2 large bore intravenous cannula, and we have to monitor the blood pressure, pulse and urinary output, and we have to take blood investigation. The urine output will be like goal will be like greater than equal to 0.5 ml per kg per hour. It indicates adequate perfusion. Okay, so we have to follow some general methods, that is nil per orifice. Okay, so this nil per orifice we have to do. Then after we have to give nasogastric tube for decompression. Why it's important? This nasogastric tube decompression is important because if patient doing like persistent vomitings, significant abdominal distension and complete shortness, small bowel obstruction and pre-operative decompression is main indications of nasogastric decompression. And it will reduces, the main benefits is it will reduce vomiting and prevent aspiration and relieve bowel distension, and it improves patient comfort. So this NG tube does not treat the obstruction, that is the main thing. But what it will do, it provides supportive decompression while definitive management is planned. Okay, next we can give here some fluids like normal saline initial resuscitation 0.9 percentage, a Ringer's lactate like volume replacement unless contraindication, and dextrose solution maintenance after stabilization if indicated. Okay, next electrolyte correction we have to do like potassium replace only after confirming adequate urine output, and we have to correct sodium and chloride abnormalities gradually. Aggressive fluid replacement should precede surgery whenever it's possible. Okay, next we have to do CT abdomen. Then if simple small bowel obstruction means we can go with conservative management. If it's strangulated, we have to go with emergency surgery. Okay, next we can see here that is pharmacological management. Pharmacological management is drug therapy is supportive. Drug don't remove mechanical obstruction, but they relieve symptoms and prevent complications and treat infection when present. So we have to give fluids. First one in fluids, normal saline like crystallite. Individualized intravenous we have to give continuously. The main thing to reduce risk of hypovolemia and to monitor, and whenever you are giving fluids we have to monitor sodium levels. Next we can go with Ringer's lactate. The Ringer's lactate like balanced crystallite to individualized. So based on patient you can select, and the route will be like intravenous. The frequency continuously we have to give the indication to replace volume, and it can cause severe hyperkalemia, so we have to check the labs. Next, potassium chloride. Potassium chloride will be like electrolytes based on serum potassium. We have to give intravenous as required how much the patient need. The indication if patient have hyperkalemia, we can start this potassium chloride. Never give intravenous potassium as a rapid bolus. Okay, next you can see here that is antiemetics like ondansetron. Ondansetron like 5-HT3 antagonist, histamine antagonist. 4 to 8 milligram you can give intravenous post oral every 8 hours. The main indications will be like nausea and vomiting, and we have to, the important thing is whenever you are using that ondansetron, we have to monitor QT interval in susceptible patients. Okay, next metoclopramide. It's like metoclopramide is a dopamine antagonist like 10 milligram you can give intravenous every 8 hours. Nausea for reducing nausea, and we have to avoid incomplete mechanical small bowel obstruction because it increases gastrointestinal motility. Okay, next we can give for paracetamol for pain, and morphine like opioids for reducing pain. It's for normal pain paracetamol, Panadol. In severe pain morphine we can use. Okay, and never give prokinetics. Prokinetics we can't give because some patients will give prokinetics if they are suspecting any other pathological condition, because prokinetics agents are generally contraindicated in complete mechanical obstruction. Okay, so next we can give here that is antibiotics. The antibiotics indications will be like suspected strangulation and perforation and peritonitis, sepsis, emergency surgery. So what are the antibiotics we can give? Ceftriaxone like ceftriaxone and metronidazole. Ceftriaxone means cephalosporins, the class of family, and metronidazole will be like nitromidazole. 2 grams we can give ceftriaxone, and metronidazole we can give 500 milligram intravenous daily every 8 hours. The duration we can see based on source control and clinical response, and we can cover gram negative and anaerobes. Next we can see peptides, piperacillin tazobactam. The class will be like you can see penicillin beta lactamase inhibitors. The adult dose we can see 4.5 grams intravenous we have to give every 6 to 8 hours. Based on clinical response, the duration, the coverage we can see broad spectrum. Next you can see that is meropenem. Meropenem, the class of drug will be like carbapenems. The adult dose will be like 1 gram, and the route will be like intravenous. The frequency we can see every 8 hours, and it reserved for resistant infections like coverage of broad spectrum. Duration of antibiotics for giving depends on operative findings, adequacy of source control, and the patient's clinical progression. So we have some regimens to treat patient condition. That is, first line regimen means first line management. We have to start intravenous fluids and NG tube and decompression and electrolyte correction and observation. So selected uncomplicated adhesive small bowel obstruction, we have to go with this first line regimen. Second line regimen of management, we have to do surgery. If conservative treatment fails, then patient deteriorates. Next, alternative options, we have water soluble contrast challenge in selected adhesive small bowel obstruction, okay, where appropriate and per institutional protocol. Next, we can do surgery. That surgery have some indications. We have to operate immediately if patient have strangulated suspected peritonitis, bowel perforation, closed loop obstruction, incarcerated and strangulated hernia, conservative management fails, and worsening clinical condition. Okay, so we have some surgical procedures based on depending on the cause, like adhesiolysis. If patient have adhesions, post-operative adhesions, we have to break it, we have to take out. So we have to do adhesiolysis. Hernia repair, resection of non-viable bowel, and primary anastomosis when appropriate, and stoma formation. Selected cases only, like patient have any cancer and this type of things, we have to start stoma for nutrients. Then after tumor resection, then after volvulus correction, we have to do. Always we have to assess bowel viability before deciding on resection. So what it means? Bowel viability. How to assess the bowel viability means we have viable bowel and non-viable bowel. Viable bowel means you can see this type of structure like pink. I'm marking here. You can see this type of pink color, and the bowel you can see peristalsis presents and mesenteric arterial pulsation presents and bleeding from cut edges. Okay, next you can see non-viable bowel like a black or green discoloration like this second picture. You can see here I'm marking here, highlighting this part. So no peristalsis, no arterial pulsation, and foul odor and requires resection. So these are the things. Okay, so we can differentiate that viable and non-viable bowel, okay, based on that color and the features and everything. What are the things I mentioned just now? So next we can see here that post-operative care, we have to continue intravenous fluids and pain control and early mobilization and deep venous thrombosis prophylaxis, and we have to monitor NG output to remove when clinically appropriate, and we have to monitor the bowel function, and gradually we have to do wound care, and gradually we have to restart oral intake once bowel functions get returned. Next we have some complications like we have like early complications and late complications. In early complications we can see bowel ischemia, gangrene, perforation, peritonitis, and sepsis. In late complications we can see adhesive recurrence, start bowel syndrome, anastomotic leak, and incisional hernia. Okay, so for follow-up we have to monitor the vitals, urinary output, electrolytes, and complete blood count, abdominal examination, and return of bowel function, and nutritional status. So these are things very important. So mostly I covered everything about small bowel obstruction. So if you want these notes and everything, you will get in Instagram and Instagram in Dr. Anand, and Telegram in MedSteps YouTube channel. Okay, so if you have any doubt, you can ask me in comment section. So mostly I covered many topics in general surgery series, like maybe like 5 or 6 topics are left. So maybe in this within 1 week we will get everything. So if you like these videos, you can subscribe my channel and you can share it to your friends. Okay, so we will meet in our next video. I'm signing off, Dr. Anand. Till the time, take